Okay, good afternoon, everyone. I hope you enjoyed lunch. I hope you enjoyed the opportunity to network with your colleagues. We wanted to give you a little bit more time to do that, in part just in some of the feedback we received last year of the content, so I hope you enjoyed that. We now want to move to the LeRoy Lecture in Health Policy, and we are honored to have with us LeRoy, who former president and CEO of Grant Makers in Health, and in whose shoes I'm trying to fill in addition to Faith Mitchell, who followed her. For our lecture this year, we're going to be honored to be joined by Dr. Ashish Jha, and we're going to have a little bit of a, as I like to call it, fernside chat for the conversation. Many of you know Dr. Jha, but he's a global leader driving public health research, policy, and practice, and he joined Brown University School of Public Health as their dean in September of 2020. He's an accomplished practicing physician. Dr. Jha is recognized globally as a trusted expert on major health issues impacting public health and a catalyst of new thinking and approaches. He told me not to read all of his bio, so I'm not going to, because we're going to also get into that, but I hope you will join me in welcoming Dr. Jha.
Right.
All righty. So, since I didn't read your bio,
Yeah.
I'm wondering if you might start just by telling us a little bit about your journey and how you got to where you are.
Sure. And as you get more gray hair, that story gets longer, but I'll try to keep it reasonably short. So I was born in India. I lived in India till I was about 9, but I went to high school in New Jersey, college in New York. Went to med school for the reason you're not ever allowed to put on your medical school application, which is my mother. My mother really wanted me to go to medical school. And I feel like at this point I'm old enough that I'm just going to come out and admit it. Loved medicine, but actually pretty early on in medical school came to realize a thing that I think many of us recognize early in our careers, which is so much of what was driving people's health, what I was seeing in clinic, what I was seeing in the hospital, had almost nothing to do with what I could manage in that setting. And so I started thinking about public health and started taking classes at the public health school. This was at Harvard in the last century. And then went on to train and have always thought about trying to balance both thinking about public health with thinking about medicine, and how they are both really important parts of improving people's health. One is not more important than the other. I just don't believe that is true, but they're both very, very important in complementary ways. And the only other thing I'll say very quickly is I've been, for much of my career, a bit of a reluctant academic. I have been an academic most of my life. I've wrote papers, got grants from some of you. But I've always thought about the goal is not to have a big CV with lots of publications. The goal is to drive change and to use data and evidence to drive change. And how do you do that? And that is not I'll give you the secret answer. There is no answer. That is an ongoing journey, and that has always been what has motivated me, is I believe that the right answers to all the big hard questions comes from evidence and data if we can just do the work better and focus on that. One quick funny part of my, so I spent most of my career thinking about domestic health policy, quality, cost, Affordable Care Act, all those issues. And then in 2015, got asked to run the Global Health Institute at Harvard. I thought it was a little bit funny because I was not a global health person, or at least not the way I thought about it. But as I started thinking about the big global health issues of our time, there were two things that I thought we are largely ignoring as a public health community. One was the global risk of a pandemic. And remember in 2017 having a conversation with a Washington Post reporter, it was a podcast, and he said, what keeps you awake at night that people are not paying attention to? And I said, that's pretty straightforward. It's the global risk of a global pandemic, likely a virus, probably from China. I sound like I was clairvoyant. I really wasn't. It was actually predictable. And then I said the thing that I left out of that little story, which is I said, almost surely an influenza virus. That's what we all expected. We expected an influenza pandemic to hit us, and there's a reason why China was likely going to be the source from that. Obviously turned out to be a coronavirus in 2020. And so I spent a lot of the years leading up to the pandemic thinking about pandemic preparedness and how do we respond more effectively. The pandemic hit, and in some ways the rest is history. The only last thing I'll say is that throughout the pandemic, I really tried staying very focused on how to be helpful to policymakers. A lot of you saw me in the public sphere. I spent a lot of time, evenings, weekends, talking to governors, mayors, health commissioners, the White House in 2020. I always said they always called. I always gave them my advice. They largely ignored it. But then they would call back again. And my take was, if you're willing to call, I'm willing to answer that call because that's what we have to do. And kept that going. So they started listening a little more in 2021 when the administration changed. And then in 2022, I was asked by the president to come and run the response, which I did until last summer. And that brings me to where I am.
Very good. So
how did I do? That was like 4 minutes
that
of
was great. That was
life
great.
in 4 minutes. All right.
So it is through that pandemic role that I think most people came to know you.
Yep.
I have definitely read some of your studies, so I know you through that work as well. But as we think about where we are, pandemic preparedness, so let's go back 2017, and I'm going to ask you that same question. What's kind of keeping you up at night as you think about pandemic preparedness, because we've moved on?
Yeah. So let me actually talk about why in 2017 I seemed like some sort of a genius. And I just want to say I was not. There were many of us who were saying this. But why would I have said that? And then as we entered 2020, and I often say we have kind of entered the age of pandemics, why do I say that? Look, pandemics happen. Pandemics have happened throughout human history. They largely happen when you get a novel infection, usually a virus, in a population that has no immunity against it, right? Why was SARS-CoV-2 such a problem? None of us had immunity against SARS-CoV-2. And so how do novel infections happen? They usually come from animal spillovers. It's not my way of saying that's what happened with SARS-CoV-2. It could have been a different way, but that's usually what happens. And then obviously when it spreads globally, right? So if you look at what's been happening with humanity over the last 30 years, the number of novel infections has been going up and up. Why is that? Way more human-animal interactions, human encroachment into animal habitats. Economic development has meant the consumption of meat across the world has gone way up. Climate change is affecting disease vectors. So all of these things are happening. And then at the same time, what's happening is globalization. I remind people that if you compare 2003, when SARS-CoV-1, the first SARS hit, China versus 2019 when SARS-2 hit, domestic travel in China increased 20-fold, and global travel out of China increased 40-fold between 2003 and 2019. That is happening in India, it's happening across the African continent, it's happening everywhere. So local diseases become global diseases very, very quickly. So we are going to see more of these kinds of things. That's the bad news. The good news is we can actually manage our way through it without having millions of people die, without having to shut down our economy, without having to do all of the things that we had to do, and ideally without having to kind of go through the deeply polarizing set of things that happened in this pandemic. We actually have the capacity and capability to do that. When I was at the White House, as we were winding down the national emergency, a lot of what I talked to the president about was how do we make sure that we are making the investments so that when the next pandemic hits, whenever that is, it could be next year, it could be 20 years from now, that we are just far more capable. And then to your question, are we more capable? I would say we are. We have made a lot of progress, but these are not gains that are irreversible, meaning if the next administration decides these are not going to be things that are going to be sustained, we can easily slip back to where we were in 2020. So I think it's very, very important. Not everything will slip back, but a lot of it can. We've built up a big national surveillance system through our wastewater program. We've made big investments in how to do diagnostics better. There's a bunch of things, but they can go away if we don't sustain them. The hard part is right now, everybody has pandemic fatigue, and the idea of sustaining pandemic preparedness has very little purchase. So we have got to keep the pressure on to keep doing at least some of those things.
And when you think about, the pandemic, we saw, of course, like huge disparities in terms of who it was impacting and just the reaction with that. What are those lessons that we need to be thinking about?
Yeah, the line I often used to say in 2020 is we're all in this together, but we're not all in this together equally. Yes, everybody, there's probably no one in this room who was not affected by the pandemic, but if you look at things like disruption, death rates, they were very disparate across communities based on who was an essential worker versus not, who lived in multi-generational households versus not, who had access to testing versus not. So there was a whole set of social factors that drove those big disparities. One lesson, at least in my mind, is that these things are addressable if you are proactive and conscious about them. When you look at the vaccine rollout, the initial vaccine rollout, 2 shots, right? Remember the fully vaccinated. And look at that by race, ethnicity, income in the United States, there really are no gaps. That didn't happen naturally. It happened very consciously. When I was at the White House, every week when we would look at our latest data on vaccinations, on treatments, and I had to present it to the President's Chief of Staff, Ron Klain, Ron wanted to see the national numbers. He also wanted it seen broken down by race, ethnicity, rurality, a whole bunch of things. Because when you make those things visible, then you understand why are we seeing gaps, and then you can do something about that. And so one lesson is if you take a conscious approach to these things, and you have an administration that cares, I would present things to the president, and he would say, Doc, you're not showing this to me for all the communities who are most vulnerable. Why not? Well, I made that mistake once. Every time I went back to him with data, I always had the other stuff backed up. So it takes somebody who cares about those things. You may not always have that. And so then the question is, how do we institutionalize collection of data, looking at these kinds of data, broken down by groups that are vulnerable? That's a very important task. That's something we got to do.
So thinking about might not always have someone who cares about that. We have an election that just happened. There's a little bit of a transition that's going to happen.
Yeah.
Let's just sort of delve into that a little bit. You spent a lot of time at the White House and sort of working with them on COVID, but obviously in your role, lots of other things. So let's talk about like what might this mean, what we might see in terms of pandemic preparedness, all the things, we'll just run through them. But your initial election reflections.
Yeah. My sense going into the election, and again, I'm obviously not a political analyst, or no one thinks I am, and I just play one on, in my own head, but there was a 50-50 chance this was going to be the outcome. At least that was, I think, I have to say I've been a little surprised at what's happened with Congress. My expectation was that the Democrats would have at least the House. That looks like that's not going to happen. I raise all of this because what that means from a policy point of view is that there are going to be very, very few breaks on the Trump administration, right? They're going to have Congress, they're going to have the White House, they have the Supreme Court in many ways. So you're going to see lots of action. Now, to your question of what do we think is going to happen around pandemic preparedness, my sense of the Trump team from the last time around is that there were 2 groups of people, just being very blunt about this. There were institutionalists, people who care about institutions, who think that our institutions have to hold up. They're conservative. They would be comfortable in any Republican administration, and they were often a big part of the Trump administration last time around. A big thing that I'm watching for is how many of those people come back in. Because the second group is really people who think that our institutions have all become corrupt and failing and want to destroy institutions. Look, our institutions have problems. I got to see a lot of them very up close and personal. The problem of breaking them is you got to put them back together. And we can talk about the problems at the CDC, but if you break the CDC, you're going to have to figure out how to put the CDC back together. And I worry that a lot of the folks that have been talking about how bad the CDC is are ready to break the CDC but don't have a vision for what putting it back together might mean. There are some very, very smart, thoughtful people who care about pandemics, who care about biosecurity, who are, I think, in the mix. If they end up in key positions, I think we'll be fine. We're going to have a bunch of policy stuff I'm not going to love, but that's okay. That's called democracy. But I'm hopeful that some of those people will be willing to go back in and serve, because they're serving not just the president, but they're serving the country. And I think that's going to be really important.
So another space, I mean, keeping in sort of the health, you talk about the work you've done in kind of the quality space and others. ACA, Medicare, Medicaid, new administration.
Yep.
This is true.
It's true.
Medicare and Medicaid are two different government programs. This is true.
Related but different.
Right? That was great.
Good. That's good.
So
I like it.
right, good segue. So yes, for those.
You just finished the rest of that. Well,
Right. What else did you have to say? Right. So
we should talk about AI. No.
talk about that too. So let's talk about those in terms of what's on the table. We had a little conversation of the subsidies and some of that, but what are we thinking might be on the table for conversations in both of those spaces?
It's a good question. Obviously, there's a little bit of tea leaf reading because we don't really know, and the Trump administration has not put out a detailed plan on health, right? Concept of a plan. Look.
They have concepts of CDC breaking too. But.
Yeah, I think that Donald Trump himself has not been particularly interested in health policy issues. And so again, this will be very dependent on who he puts into these positions. Last time around, for instance, the CMS administrator was Seema Verma. Did I agree with everything that Seema did? No. Did I think she was smart, competent, and trying to do right within the political guardrails that she had? I do. I think she was a pretty good administrator in the context of an administration that I don't necessarily agree with. You know, you were there, so you have a more up-close and personal view on this. But if we get another Seema Verma-like person, I think that a lot of the policy stuff, again, that won't be completely aligned with what I want, but it'll be fine. Here's where I think we are going to see some things, right? Like, so we still have 10 states that have not expanded Medicaid. I've been hammering on that. I can hammer all day. I don't know that we're going to see much more expansion. We might. I mean, Mississippi got close. What is going to happen just on the Medicaid side is no question about it. Any states that do further, they're going to put in work requirements. We can talk about work requirements as a policy issue. My personal view is the data suggests it's more bureaucracy, it's more expensive, it prevents some people who are eligible, and doesn't really cause anybody to work. So from a pure policy point of view, it's like not really particularly useful. But it may get enough states to think about this seriously, and you're going to have a CMS that's going to be much more willing to let states experiment. So the irony is we might get some of those states actually expanding Medicaid with restrictions that I wouldn't necessarily put in, but I will take Medicaid expansion wherever it happens. That's a lot of poor folks who are going to benefit. In the Medicare side of things, as you all know, the big thing that has happened in Medicare is we have gone from, where were we, about 20% Medicare Advantage in 2010 to 55% Medicare Advantage. Medicare Advantage has taken over Medicare. And in the last year, 18 months, there have been attempts by the Biden administration to put some brakes on that, to make some policy changes. I think those brakes come off. And if I were a betting person, and my track record on betting on this stuff is very bad, so I wouldn't put a single cent on this, but we're going to be at 70, 75% MA at the end of 4 years. So we're just going to see a lot more Medicare Advantage. And there have been some excesses and problems with MA that I don't know if they're really going to go after. The other thing we're going to see is the proliferation of short-term plans. This has been very controversial. I'm not a huge fan of them. A lot of these short-term plans don't cover basic essential things like drugs, but they're cheaper. And I think you're going to see an administration that's more willing to experiment with these things. And then the big question in my mind is there actually going to be a serious effort to repeal key provisions of the IRA? As you know, there are big subsidies. I remind people, by the way, that the big ACA subsidies, here's a question. Do you know what proportion of people in Miami-Dade County are on an ACA plan? 25%. on an ACA plan. Then throw in Medicare and Medicaid, it's about 65, 70% of Miami-Dade. The biggest states benefiting from the big subsidies in the ACA from the IRA and others are like Florida, Mississippi. They're all red states. So it's going to be a pretty tough political pill to withdraw that. The other question is about price negotiations with pharmaceutical companies. Pharma companies hate it. The first set of things weren't that bad. My hope was that we expand that. I don't know if that's going to happen. So my best guess, but those are all like some ways almost predictable for almost any Republican administration, and I'm hopeful that that's what we'll see.
So I'm going to ask this next question, a bit knowing what I think the answer is going to be, and then I want to start to pivot to the where do we go, what do we do? So the Biden administration on day one had executive orders around health equity. As you noted, being held accountable for reporting that out, the agencies all had plans. Yep. We'll just assume that's all disappearing.
Yep.
So what are the opportunities to think about, how we continue pushing on health equity?
Yeah. It's a very good question. I assume that the very explicit, like the executive orders, the other things are going to get yanked very early in a Trump administration. A couple of things. I mean, one is we spent a lot of time in the Biden administration trying to really embed collection, data collection. You did a lot through CMS when you were at CMS, but there were a whole bunch of other efforts. We just got to begin to be able to collect data on race, ethnicity, income, rurality. So first and foremost, we've got to look at equity issues beyond race and ethnicity. Everybody in the room knows that. But I think to the extent that we keep bringing in other vulnerable groups like rural Americans, people who live in rural areas, that is going to make it a bit more palatable and it's going to build a bigger coalition. But I think my hope is that ability to collect data, to look at data, has gotten enough embedded into agencies that the people who work in those agencies, I don't mean the political appointees at the head of the agencies, but the people below them who are career folks, will continue to look at these data in those ways. The question that's a harder question to answer is like, what's the action step and how much political will is there going to be? Again, I think if we can couch this more broadly as really taking care of vulnerable Americans, who I'm hopeful that there is going to be some appetite for that. If it's purely a focus on race and ethnicity, I think it's not going to work so well. But I think if we can look at this, but it shouldn't just be focused on race and ethnicity, right? There are lots of people who live in rural areas who have a very hard time accessing care, who have substantial challenges with their health and health outcomes. Again, I think to the extent that those issues can get reframed in that way, I'm cautiously optimistic that the administration is going to be open to acting on those. But then the last part I'll make on this is the federal government's important, but they're not the only game in town. States have a very big role to play here, and I think a lot of this stuff will move to states, and you're going to see a lot more action in states on these things.
It's a great tee-up for our next session that we're going to talk about what's happening at the state level. I think, so a couple of places I kind of want to go because you're the dean of a school of public health. Yesterday we spent some time talking about public health and how we protect America's health. We have a young med student in the room, and so as someone who's training that future workforce,
yep.
And we have some real healthcare workforce challenges.
Yep.
Like what's on your mind, and what are you thinking about? How are you approaching that? Also with that lens of you've done a good job diversifying your student body there.
So I'll give you some like specific numbers and specific strategies and how we've thought about it, how I've thought about it. When I arrived at Brown at the School of Public Health, these numbers are approximately right, about 6% of our students were African American, about 4% were Latino. I would just say we did not have a particularly diverse student body. Those numbers right now are at about 25% African American and about 22% Latino. How do we do that in the context of a SCOTUS ruling that makes race-based admissions? We didn't take a race-based approach at all. Because it was even 4 years ago, it was clear that this was not, race-based admissions was going to fall. So the strategy we used was we went out and built relationships with institutions. We built a whole bunch of relationships with HBCUs, historically black colleges and universities, and created essentially a feeder program where HBCU graduates can come and get their Master's of Public Health or a Master's of Science in Biostatistics or one of our other degrees at Brown. And what we have found, and we did that with Hispanic serving institutions, we're working on that with places that have relatively rural populations. The idea, look, there are a ton of super smart, talented young people for whom the idea of going to an Ivy League school just never crosses their mind. And to me, that's not on them to fix. That is on us to fix. And we've got to show up, and we have got to build long-term relationships, and we've got to be trusted. And it's like, it's not just, okay, we build a program and people can apply. You know, the first class that came in from this program that we created with HBCUs, we had a bunch of folks, young people who, you know, I remember one student talking to her, like day 3 of orientation. She had grown up in rural Mississippi, had lived her whole life in rural Mississippi, had gone to Tougaloo College in Mississippi. And the idea of coming to Providence, she's like, I don't know where I'm going to go to get my hair done. I don't know where I'm going to go to, like all legitimate, real questions. And we've got to be an institution that can deliver on those things. And so I'm not suggesting we had it all figured out on day 1. We did not. But we have learned, we've worked really hard. And at no point in any of these efforts has there been a race-based effort to try to diversify. It's been, let's build opportunities for places that don't generally feel like they have opportunities. And if you do it that way, you end up with a much more diverse workforce. I think there are a couple of reasons to do it. One certainly is, when I've looked at the public health workforce and public health leadership in America, I've said for years, the public health workforce is reasonably diverse. The public health leadership in America is not particularly diverse. And we've got to change that. And so when I arrived 4 years ago, I said, we have got a generation to make this change. And the way we're going to do it, and the role we are going to play is we're going to have a cohort of students every year from HBCUs, for instance. And they're going to be networked. We're going to build mentorship programs for all of them. And over a decade, we're going to graduate hundreds of them. And hundreds of students deeply networked with each other, tied to an institution or multiple institutions, is how you change the face of public health in America. And that's been the agenda. And I think in general, it's been going pretty well. We'll see what it all looks like 10 years from now, whether it's really worked. But the first couple of graduating classes are off doing great things. They're young. It's going to take them a while to climb the ladder of leadership. But we've got to start making those investments. And as a university, I felt like, or as a school of public health, I felt like that was really important. The second part of the way I've thought about this, which may feel the opposite, it's not in my mind, is one of the things I said to our education program folks is so we're in Rhode Island, pretty blue state. I was like, look, we are not training public health leaders to go work in blue states. Some of our public health leaders will go work in blue states. But I need our public health leaders to go work in purple states and red states. And our faculty do not know how to train our students in those contexts. Let's just be honest. We don't have a very politically diverse faculty. I often say jokingly that, actually we have a lot of political diversity. We have everyone from Marxists to liberal Democrats. You know, but just being honest, right? Like, it is true. If you look at the voting, if you look at the donations from schools of public health, faculty and staff who work at schools of public health, you look at their donations as publicly available, it tends to run between 99 and 100% Democratic. For a country that's split, to me, that is a huge problem. It's a huge problem in public health. So one of the things that we've done is gone out and recruited people who worked. I'll give you an example. Scott Rivkees. Anybody know Scott Rivkees? Scott was a Surgeon General of Florida. That's the highest ranking health officer of Florida from 2019 to 2021. So for the first year and a half of the pandemic, he ran the COVID response for Governor DeSantis. And Scott did a pretty good job. And it was a complicated job. He didn't get renewed. But he understood how to work in Florida under Governor DeSantis and did a good job. And so as soon as he was wrapping up, I said, you should come to Brown and teach our students. And so he's now a professor at Brown, and I'm trying to teach our students that, look, half the country thinks of public health in a very different way than the other half of the country does. And we have got to train our students to be public health leaders for the whole country, not just for half the country. And I think that's a really important part of our agenda that I don't see enough public health schools doing.
And as you think about sort of the future of public health, so that diversity, the building relationships with community, making sure that people can go and understand the communities that they're going to be working in that are not just blue, and you are the ocean state, nice blue state. What else should we be thinking about in terms of training that future workforce?
Yeah, something that I think about, but I don't feel like I've made much progress on yet, but my goal for this year. It's been a complicated 4 years. I was gone for a year and a half, so I feel like there's a bunch of things I wanted to do that have gone a little more slowly. But I really do think AI is going to be transformative. I know you jokingly brought up AI when somebody's computer spoke up earlier, but AI in my mind is a bit like electricity 120 years ago. When electricity first came out, before electricity, we had mechanical systems that did all sorts of stuff. And when electricity first came out, everything kind of just got electrified, but it was basically the same system with a little electrical motor attached to it. Then over time, people started reimagining what you could do, and the world really changed. I mean, it's hard to, in fact, think about all the ways in which electricity is just something we take for granted in almost everything we do. That is, in my mind, AI is about as profound as that. I know it feels a little hypey right now. Can't go to a talk without somebody bringing up AI. I'm sorry, I'm that guy today. But I think AI is going to be transformative. And one of the things that I have been thinking about, but I will be the first to admit have not done enough on, is how do we train our students to have work that is relevant in a world where AI will be ubiquitous. And that is really important work for us to do, because I haven't seen any med school, public health school, really solve this. Probably can't be, at least you got to begin that journey, and we're working on that, but I do think it's going to be pretty transformative.
So thinking about and pivoting to the where do we go from here, you've got a room of funders. We started our morning off by sort of having our one-word reflection on the election. I will say they were not very exciting and positive. I think we're now moving into our next phase, and we're sort of ready to fire it up and ready to go.
Yep.
So where do we go? What do we do? How do we move forward?
Yeah. So, look, there are some really big issues that are not going to get, I think, enough attention. One I want to start with, I mentioned this earlier, is the health effects of climate change. Climate change represents, in my mind, probably the biggest threat to human health, not in 20 years, but like over the next 5, 10, 20 years. There's a ton of work that needs to be done to understand it, to plan for it. And I've been talking to a lot of the scientists who work in this space in the last week, and they're very worried about what's going to happen with their funding. And they're already pivoting to talking not so much about climate change, but about extreme weather and all the other things that you can talk through. But I think the way I have thought about this is society's complicated. Like, we have government, we have private sector, we have civil society. Y'all are part of civil society. You're not government, you're not private sector, you're civil society. Universities are civil society. Foundations are civil society. And when government leaves certain things aside that need to be addressed, it is really important for either private sector or the civil society organizations to step up and fill that gap. Now, we all understand that, like, when it comes to thinking about research or stuff, we're not going to fill gaps from the NIH. That is just a behemoth. But there are really important areas that we need to continue funding and making sure that if we just have a 4-year period where we just stop paying attention to all of the health effects of climate change. By the way, those health effects, we're all in this together. We're not all in this together equally, right? If you think about which communities are going to be most harmed by climate change, it is not the wealthy communities, and maybe like the the beach, the Miami Beach folks, but like in general, the people who are going to be really affected are the people who have the least amount of resource and resilience. So there are important issues like that I think we're going to want to watch what happens with the administration, and then really think about where can funders come in and fill some of those gaps to keep some of the work going in ways that are going to be really important.
And with some of the other things related to the administration, going back as we think about, sort of the Medicare, Medicaid, ACA, quality, health, like state policy,
Yeah.
all of those things, what else are you thinking that to-do list starts to look like?
Yeah, so good. So beyond, obviously, climate change is important, but look, the other thing I always remind people of is we probably as a country, and this is not just trying to set up your next panel, but we as a country probably focus a bit too much on federal policy on health. Much of what happens in health happens at the state level. And I always remind people that most federal policies happen because some states tried it first and it worked. However you feel about welfare reform in the late 90s, it was because Wisconsin and some other states did welfare reform, led to national policies. The Affordable Care Act did not come out of nowhere. Massachusetts health reform essentially in many ways showed that it could be done, and that became the model for the Affordable Care Act. So if you think there are important things that need to be done on cost, quality, access, and we find an administration that's not super excited about doing it, the key is at getting it done in states. It's also easier to do it at a state than it is at the federal level. We're a very diverse country in terms of political and geographic and healthcare landscape. So in some ways, often very much easier to do it at the state level. And we should be doing more of that, and we should be funding more of that. I mean, look, on the issue of affordability and how do we make healthcare more affordable. We've talked a little bit about this at the national level, drug prices, other things. Most Americans get their healthcare, a majority of Americans get their healthcare through private insurance. And then if you throw in Medicaid, which is also state-driven, that's like 70, 80%. States have a ton of leverage. So finding state policymakers who are willing to try out new care models, new ways of improving access, new ways of preventing medical bankruptcy, that is all going to happen at the state level. And if we're super successful, then we can talk about how do you federalize it and how do you nationalize it.
Okay. So with that, I want to open up for questions and invite folks to the microphones.
Shy group.
Not at all.
Dr. Jha, this is Arun Karpur from Peterson Center on Healthcare. One of the things that we have confronted when you talk about the cost of healthcare is increasing abilities of purchasers in understanding how that's impacting them and using their own data to be able to then take some action as a result. What's your sense that the changes in political climate might have any impact on that thought, that it's the purchasers who may and should be prioritizing looking at their own data and then making decision on behalf of their employees?
Yeah, so this is like businesses, the big purchaser. Can I give you an answer that's probably going to make me less popular, and you may disagree on this. This was, in my mind, the big hope like 10, 15 years ago when you had these national, the business group on health and you had all these efforts. I have become far more skeptical that businesses are going to do anything here. My sense is that as costs have gone up, they find it perplexing and complicated, and they decide that they were going to weigh their manage it just by passing more costs on to their employees. More high-deductible health plans, more co-pays, those kinds of things. And in the ideal world, purchasers who write the big checks, especially self-insured ones, you would think would say, this is like 20% of our budget. We should negotiate aggressively with the hospitals. They just haven't been willing to do that. And I think it's a combination of being afraid that they're like going to end up being locked out of a network that their employees care about, but also they don't feel like it's their expertise. And so I've been pretty consistently disappointed with what feels like big potential, but purchasers not stepping up. I'd love to see an alternative. Like, I'd love to be wrong. But I've just given talks in front of so many purchaser coalitions and given them ideas of what they can do. I just don't think it rises to the top of the list of what their priorities are and what they think they're good at. And I think that prevents them. Sorry, that's a little bit of a negative answer, but I just...
No, here we go. Okay, Rita? And then we'll go over here.
Great, thank you. So first of all, thank you for all your leadership during the pandemic. Really appreciate it. My name is Rita Carrion. I'm from Unidos US. And one of the things that we have a lot to learn from the pandemic, especially of how our community-based organizations really were well invested in their ability to be the trusted messengers to our communities, and seeing that elimination of disparity on the first COVID shots. But there's a lot that is not being said, or just in your experience with the pandemics and over the next 4 years, currently with the avian flu, and that impact to farm workers, that's not currently being talked about.
Yep.
What's your take on the next 4 years of a potential next pandemic? And do you think this upcoming administration will continue with the Office of Preparedness and Policy Reform?
Yeah.
So 2 questions, sorry.
Several good questions there. So let me unpack this a little bit. First of all, community-based organizations were the lifeblood of the vaccine response in 2021 and 2022. And I relied on them for a lot of things that we try to get done. They are not just, I mean, they're super trusted. That's obviously probably the biggest advantage they have. They also just know their communities. They know how to reach them. They know how to connect with them. And they were extraordinary. We did a whole bunch of events at the White House where we basically invited them in just mostly to thank them and keep them going. Unfortunately, these community-based organizations require funding. I don't mean unfortunately like I wish, but that's just a reality. And that funding has dissipated, and that's a problem. And we tried to keep some of that funding going, but some of that got clawed back. So my view on that is, we've got to find other ways of engaging these organizations on issues other than vaccines and pandemics and other things that obviously we don't have as much funding for. One of the things we did create before I left the White House was the Office of Pandemic Preparedness and Response, OPPR. We felt it was very important to have this. We actually got Congress to pass in the omnibus the creation of this office, and then got it that I think helps sustain it. Here's the real bottom line though, which is who's going to run that office? Because if it's somebody who's pretty committed to thinking about preparedness and making sure we're on a response footing, it'll be great. But if they either decide not to fill that office or put in someone who is not really committed to doing those things, you can have the office. It's just not going to do much. Right? These are all sort of soft power positions. And like I always reminded people, my official title was I was the White House COVID-19 response coordinator. I was a coordinator. People were like, you're the COVID czar. I'm like, I don't know, czar sounds powerful. I can ask lots of people to do things, and if they say no, I can ask nicely twice. But the power of these roles come from the soft power of what you can bring, your ability to persuade people, your ability to use other levers. I don't know whether the next administration is going to have someone in that role. So even in the last week, a lot of what I have been doing is talking to people who might play that role and figure out how to persuade them to consider going in and doing that.
Thank you. Susan?
Yeah, hi, Susan Mims with Dogwood Health Trust in North Carolina. Thank you for being here and sharing your insights with us today. And I appreciate the hopeful message of what we can do, and you talked about working through states. And I'm thinking about some of the ways that the states work with the federal government to be able to do those innovative ideas, such as the Center for Medicare Medicaid Innovations and thoughts like there, as well as 1115 waivers to think about how to do these innovative care delivery models in the states. My question really is, as we look at trying to do those things, do you have any insights or suggestions for states in those conversations with a new administration that would allow those innovations to be, continue and to be more successful?
Yeah, it's a great question. It's hard right now because we're a week. I mean, the election, like a week ago at this moment, we didn't even know who the next president was going to be, right? So we're still very fresh. We don't know who the HHS secretary is going to be. We don't know who the CMS administrator is going to be. But I agree with you, and I love North Carolina, and Cody Kinsley is like, I was going to say he's the greatest health secretary in the world. That's a little exaggeration, but he's awesome. He's pretty much there. But there are states that have a very strong track record. My sense is that in the last time around, look, predicting the next 4 years is very hard. I don't know who's going to be in. And there are going to be important differences between a second Trump term and a first Trump term. But the best ability to predict what's going to happen next is to look back at what happened in the past. Not because it's perfect, but it's better than almost anything else. And as I said, if it's someone like Asima Verma at CMS, in general, I think the administration is going to be open to more flexibility, more waivers. They had pretty good people running CMMI last time around. I don't want to be overly like rosy, rose-colored glasses. It'll be great. I don't know if it'll be great. But I would not get particularly despondent on this stuff. I suspect there's going to be a good amount of flexibility. It's just we're going to have to see who the HHS secretary is going to be, and then we're going to have to see who is going to run CMS. And that will drive so much. And in some ways, the HHS secretary, because that sets the tone for the kind of people we're going to see down the path. So I wish I had a better answer for you, but let's check back in a few weeks.
Thank you.
Hi, Dr. Jha. Thank you so much for being here today, and thank you for your service. My name is Ashish Jha, and I work at Protect Our Care. In a previous life, I was also a coordinator at the Biden White House, so, same level. I'm just kidding. But my question to you is about communicating during times of public health crisis. I think I come from the scientific community, so do you. And I think the scientific community, we're very good with handling uncertainty and what we don't know. And during times of novel viruses, that evolves over time. So while some people might think that the CDC got a lot of things wrong in the first year, they were just going based on the best evidence that they had at the time. So I think my question to you is, how do we get the larger public to kind of adapt to the way that the scientific community handles uncertainty, and how do we communicate clearly despite that level of uncertainty that we can have?
Yeah, it's a very good question. And I'm going to push back a little bit on a couple of things there, because so the whole point of early days of a pandemic is there's a ton of uncertainty, right? You don't know much about the virus. You don't know much about the immune response. I think things that I learned that I saw, or mistakes I saw that I tried not to do, and I'm sure I did some of them, is don't overstate what you know. Right? We often got stuff wrong because we were like, this is the right answer. But at the same time, and this is where the balancing act is, you don't want to flip it and also say, I have no idea what's going on here. Because that's not helpful. Because the general public's like, well, we also have no idea. So you have no idea, I have no idea. This is not great. So a lot of what I tried to do in those moments is share my best assessment based on where we were. And I said, by the way, we don't know. Here's what I think is likely to happen. Here's where I think we are. But here's the part where I'm going to, I think, slightly disagree with one part of your question, which is when you say that, you're essentially making a promise that when you get better information, you're going to come back and correct. And if I have a criticism of the CDC, they got some stuff wrong initially. They're not perfect. That's okay. But when we got updated information that their initial assessments on some things were wrong, there was this massive resistance to updating because they're like, people are going to lose faith. You know how people lose faith? Is if you don't tell them what is actually happening. I never found that if I went on TV or elsewhere and said, 3 months ago I thought it was this, it was wrong, I was wrong, new evidence says this is what it is. I did not think that undermined my credibility or made people think the guy doesn't know what he's talking about. In fact, I felt like it sort of bolstered it because I was being honest with people. There were things I got wrong. I feel like one of the lessons of the pandemic is we have to be willing to admit where we've made mistakes and update it as quickly as we can. And too often we worried that somehow that would undermine our credibility. I think people understood we were in uncharted times. They wanted honesty and they wanted updates when you got new information. And that's a lesson that I think the scientific community's got to do a better job at.
Thank you. And with that, please join me in thanking Dr. Jha for
Thank
joining
you.
us.
Thanks so much.